are given to us. Okay. So duration of each video is 8 minutes. Changing of the presenting author is not allowed. Is anybody has changed the author here? Okay. Um, so please do not consult your marks with other judges. So we value your individual evaluation. So, we'll be marking and giving the envelope to them, and they'll take an average and decide. That is what is the protocol here. And results announced are subject to ratification by the scientific committee office. So first, let me start off by congratulating you all. It is really tough. I believe this is the toughest award to win. Unfortunately, as we're discussing, it's not getting the due coverage and recognition as it is because we've got multiple, specialities competing for one grand prize. And ideally, it should have been that, the judges from different specialities should have been there. Unfortunately, it is not happening here. So let me introduce myself. I'm Dr. Deepak Megur. I specialize in anti-segment surgery. Ma'am, you can introduce yourself.
Hello, I'm Dr. Indira. I'm glaucoma consultant, Arvind Eye Hospital, and last time award winner CS Reshmi.
Okay, I think with that we can start the first presentation. May I request Dr. Kumar, can you please come and start your presentation? I would request
Technical team.
the technical team to, can you just dim this light a bit so that the screen, although very few people are there, they can see better. Can you just dim this light? So your video number is VT85.
Oops moments in cataract surgery, handling intraoperative surprises. These surprises can occur at every step of the surgery. Incisions, CCC, hydro, phaco, IA and IOL placement.
When there's something strange and the keratome slips, the capsule screams and the MVR hits. Who you gonna call? Oops, busters!
At times the keratome can slip and nick the anterior capsule. Solution to this is to start the rhexis from the same side and engulf the entire nick in the CCC to prevent a rhexis runoff. Such wound leaks can cause an unstable chamber. A simple technique is to take a sharp keratome and create another parallel incision in the roof of the original incision. Hydrate the same with the cannula and you'll be surprised to see that the wound leak stops.
We spin the needle and flap goes west. Down comes the news, giving us stress. Who you gonna call? Oops, busters!
An accidental puncture of the anterior capsule can happen while injecting the viscoelastic in the AC. Reform the chamber and start the CCC from the same site of the puncture, go all around and engulf the puncture site. An accidental puncture of the anterior capsule happens with the keratome. Form the chamber with the viscoelastic and start your CCC from the site of the puncture. It's important to go around and make sure the site of the puncture is completely covered. And this will ensure the CCC does not give way and the IOL centers in the bag. While performing rhexis with Utrata forceps, sometimes viscoelastic leaks. One must reform the anterior chamber, but re-attempting a rhexis will cause a leak and this can lead to a rhexis runaway. To prevent this, reform the anterior chamber and use a microrhexis forceps through the side port, go all around grasping the CCC to complete it.
A tiny rhexis, oh is that bad? Pop comes the sound. What the hell was that? Who you gonna call? Oops, busters!
When a small CCC is created, there is always the fear of a rhexis blowout during hydro procedures. In such cases, to perform in-the-bag phacoemulsification, reduce the bottle height, lower all parameters, observe the flap motility sign in phacoemulsification and in IA. Do not allow the chamber to collapse. Carefully inject the IOL. nudge it into the bag without dialing it to complete the case successfully.
The probe's at work, tricks up its sleeve. Don't go hunting, the water's deep. Taking a dive, it's time to weep. Who you gonna call? Oops, Busters!
In a soft cataract, there is a good chance there will be a crater formation. This leads to thinning and you can see a beautiful glow coming through. If the pupil is smaller than the size of the rhexis and there is a crater formation, we can use either hooks, viscodilation or continue struggling. The ideal choice would be to use hooks to get better exposure and perform safe phacoemulsification to prevent any complication. A case of weak zonules and a dense cataract, one can successfully complete the rhexis, but for a safe in-the-bag phacoemulsification, we have to lower all the parameters. But at times, the bag may tend to follow the nucleus and one can have a zonular dialysis. Of course, perform an anterior vitrectomy after staining the vitreous and insert an endocapsular ring from the area opposite to that of the zonular dialysis, followed by irrigation aspiration, which is tangential and not centripetal. This will release the cortex, which is entrapped by the endocapsular ring. This is followed by in-the-bag placement of the IOL. Make sure the IOL is not dialed all around and the haptics additionally support the area of the zonular dialysis. In another case during phacoemulsification, we face intra-op meiosis. Even viscodilation does not help and the meiosis continues to worsen. In such scenarios, a ring can really help. But it is very important to make sure that the loop of the ring is not entrapping the CCC. We can release the trapped margin of the CCC from the loop before IOL implantation into the bag. The lens can then safely be placed into the bag. The ring which was placed can be easily removed.
The eye is tricky, CCC in shreds. Don't pull the tag, steer clear my friend. Who you gonna call? Oops, Buster!
During bimanual IA, misdirected fluid causes iris prolapse. So we reposit it, change our hands and direct the irrigation to correct the flow and prevent iris prolapse. This completes the IA successfully. In another case, while performing IA with a coaxial probe, one may accidentally hold the posterior capsule because the irrigation port is in the incision itself. In such scenarios, it may be wise to shift to a bimanual technique after IOL implantation to remove the subincisional cortex. In yet another case, while removing the viscoelastic from behind the IOL, the haptic can pop out from the bag into the anterior chamber. It can easily be put back into the bag under irrigation using Sinskey hook.
It flippity flips and sometimes slips. Oops, oh no! The eye's in splits. Who you gonna call? Oops, Busters!
During IOL implantation, it may flip. Place viscoelastic to protect the posterior capsule and the cornea. One can flip this IOL and orient the haptics correctly. Then the superior haptic can be dialed into the bag. While inserting single-piece hydrophobic IOL, one would have seen stuck haptics, but this is something different. The haptic is actually held on by the body of the IOL itself. Nothing to worry, the haptic actually just releases itself and the IOL orients itself in the bag. In some cases, the haptic is trapped between the plunger and the cartridge itself. Don't be impatient. Cut the cartridge away from the haptic. This itself will release the haptic. Once the haptic is released, very simple, just dial it into the bag.
Scream, shout, fear no more. Chin up, and so. Who's got your back? Oops, Busters! So hold your wits and grace, cause in the end you'll find your place. Who's gonna call? Oops, Busters! Who you gonna call? Oops, Busters! Who you gonna call? Oops, Busters! Who you gonna call? Oops, Busters!
Thank you.
Thank you, Dr. Kumar. It was wonderful. Dr. Indira, you have any questions to ask?
Sir, I have one question. So, one of my residents, what they did, you showed one video, I think, Visco directly injecting to when the capsule was intact, sir. So, similar during the just adrenaline injection, they poked the
Yes.
ALC and then the adrenaline was inside and then flag sign happened, sir. So after that, do we like directly go into the like Rexis or like we stay in because already the if it was a mature cataract, so everything got disturbed.
So you can still put air, still put a dye,
Yes, sir.
and it depends on the direction of your Argentine flag sign.
Yes,
Then the
sir.
target would be still to, because anyway it's stone, so the intralenticular pressure is already decompressed. So I would still go ahead, put some air, then still stain the capsule. Once you stain, then put in a heavy viscoelastic, and then try to make a rexis of the rest of the part of the tear. And then watching the flap motility sign of Dr. Rohit Om Prakash, put all your bottle height, all your parameters low, and do a slow in the bag phacoemulsification.
Yes,
But
sir.
you can still complete it if all this is looked after.
Yes, sir. And one more thing that in the same direction you told, sir, like what did you mean by that? Like in the same direction where you have made that just entry.
So what I meant was, this was while putting methyl cellulose into the AC.
Yes, sir. Yes,
So I
sir.
made my incision, and then you want to put methyl.
Yes,
So
sir.
normally what we tend to do is go to 6 o'clock, keep injecting the viscoelastic and keep coming out.
Yes,
And then
sir.
we observe the pupil slightly dilate, and that's when we stop. So while going in, if it's a shallow anterior chambers, nowadays we very much look at the ACD. So if the ACD is 1.9, 2.2, there is a chance that when we go in with the viscoelastic cannula, it may puncture. But if you observe at the right time, stop injecting, come out, put a heavy viscoelastic, and wherever we are punctured, start the CCC from there and go all around. It's very, very important, and this we have found even in femto, that wherever the nick is, that whole nick has to be engulfed in your CCC. Otherwise, that spot is a weak spot, and that spot can give away any time during surgery. Either phaco, IA, lens implantation, that can also happen.
Yes,
So
sir.
it's
Do
very
we
important
make,
that we go all around it.
Do we make like lot of people like they say that two rexes?
You can do a spiral. If you need, yes, you can do a spiral. Again, that depends on when you realize your puncture has happened. If your puncture has happened and it's a big puncture, then in one shot only you can go around it. If it is a small puncture, you can make one spiral and then go all around it. Again, it depends on the kind of the nucleus or the cortex or the kind of cataract that we are dealing with.
Okay, sir. Thank you, sir.
Thank you.
Next would be VT330, the ifs and buts of lacrimal irrigation. Dr. Khare Mukesh.
Good morning. May I have my video?
You have to
open it from okay.
the laptop, it seems.
Okay.
My dear chairpersons and fellow
Just a second.
delegates,
Okay.
lacrimal irrigation is the most commonly done test to assess the patency of lacrimal excretory pathway. But lacrimal irrigation cannot localize the site of obstruction accurately. A single finding may have several interpretations. For example, a clear regurg from opposite punctum may indicate blockage at common canaliculus or in the sac or in the NLD. At times, the traditional understanding of lacrimal syringing is just a supposition. This young girl with congenital lacrimal fistula, FDDT revealed freely patent lacrimal pathway. No exude from the fistula could be seen. Lacrimal syringing indicated presence of saline in nasal cavity. Some amount of saline oozed back from lacrimal fistula, and perhaps some of the saline wriggled back to the conjunctival cul-de-sac. To confirm the regurgitation, repeat syringing was done with colored saline, and we found a good amount of fluid wriggled back. We don't have any mechanism to calculate how much fluid wriggled back. It is a common knowledge that lacrimal irrigation does create a hydrostatic pressure. We conducted a simple experiment. We threw camelining of different colors in air with the help of 1 millimeter, 2 millimeter and 5 millimeter syringes with same cannula and same person. And to our utter surprise, the throw traveled 8 to 9 feet of distance. We may conclude from this experiment that lacrimal syringing does create a very high pressure. That is why the throw traveled such a long distance. Because of poor reliability of lacrimal syringing, we started looking for other tests. FDDT is the number 2, but it cannot localize the site of obstruction. Lacrimal scintigraphy has its own limitation with very poor anatomical details. We were looking for an alternative without these limitations. That took me to my physiomaxillary radiologist regarding the cone beam computed tomography machine. CBCT is a dedicated CT scan for dentistry. We have been doing DCG with the help of CBCT since 2017. CBCT DCG is done by installation of dye in conjunctival cul-de-sac. I repeat, dye is instilled in conjunctival cul-de-sac. Patient remains seated upright, normally blinking, and imaging gets completed within 13 seconds, making it a very safe procedure, and at the same time, all the physiological requirements are met. CBCT DCG provides excellent anatomical details and localizes the site of obstruction accurately. CBCT DCG utilizes the physiological forces to propel the dye along the lacrimal tree. This staged video of CBCT DCG images showing the flow of dye from canaliculus to sac, NLD, and to inferior meatus. This middle-aged woman with patent syringing, FDDT revealed obstruction on right side, CBCT DCG revealed pooling of dye in lacrimal sac, indicating blockage at the junction of sac and NLD, while the left side revealed presence of dye in inferior meatus, indicating its patency. And then we injected the dye, and syringing pressure easily negotiated that blockage. Dye started flowing through the NLD, and just watch the pressure at which dye is squirting in inferior meatus. This gentleman with patent syringing, FDDT revealed obstruction on both sides, CBCT DCG revealed pooling of dye in mid-segment of the NLD, indicating blockage. And then we injected the dye, and the syringing pressure easily negotiated this blockage, which was a dacrylith, and dye went all the way into inferior meatus. This lady with patent syringing revealed obstructed lacrimal pathway on left side with the help of FDDT. CBCT DCG revealed obstruction at the level of common canaliculus, and then we injected the dye, and syringing pressure easily negotiated the blockage at common canaliculus. Dye started flowing through the NLD, showing multiple partial blocks. One more patient With patent syringing, FDTD revealed obstructed pathway on right side. CBCT-DCG revealed enlarged sac filled with dye, indicating blockage at the junction of sac and NLD. And then we injected the dye, and even in this case, the syringing pressure negotiated the blockage and dye went all the way into inferior meatus. Hence, lacrimal syringing is not a reliable test either for screening or for final diagnosis. Back to our first case of congenital fistula, and here CBCT-DCG revealed patent pathway, no regurgitation back to the conjunctival cul-de-sac scene. The fistulous tract got highlighted, but there was no exude from fistula. To conclude, lacrimal syringing application needs rethinking. CBCT-DCG is best physiological tool to assess lacrimal passage. It can pinpoint the site of obstruction. CBCT-DCG has in abundance what lacrimal scintigraphy lacks. CBCT-DCG costs ₹1,000 only to the patient. Thank you.
Thank you. Thank you.
Thank you, sir. That's a wonderful presentation. So again, I am not in the oculoplasty field. Again, that is the limitation which I'm not aware of the developments in this. So very interesting concept. Has it been practiced routinely before, the CBCT?
This is the first presentation. So far, no one has showed the live flow of dye through the nasolacrimal duct and negotiation of the obstruction. So far, we have 840 plus cases of CBCT-DCG. We are ready to publish it. And in 2019, I presented in AIOS the other of the CBCT-DCG series, and it was adjudged as the best paper.
And the question which I have is, what are the potential disadvantages or side effects from the CT-CBG to be used as a routine screening tool for every patient with epiphora?
Well, every patient of the epiphora doesn't need CBCT-DCG. The patients who have persistent epiphora with patent syringing needs this DCG, number one. Number two, CBCT-DCG gives the exposure of radiation if supposing we use full jar, only 600, less than 600 microsievert radiation, while for the same scan by medical CT scan, it is 2000 microsieverts. Hence, it is very, very safe. And if you would have seen it, the whole thing completed within 13 seconds only.
And I saw the video in which it's an enclosure totally. Patient is keeping the chin there. You have access to do the syringing live?
No, that is something which I would not like to disclose. But what we do, we intubate the lacrimal canaliculus, and then the my assistant does it pushing from the distance.
Yeah, because that was your video you showed.
You cannot.
You cannot, yes,
you cannot.
absolutely.
You cannot.
So you have a tube connection.
In one video, there is a
Yeah, live I can see the live dilatation of the lacrimal apparatus happening. So I was wondering how the tube has come out and you're syringing from outside. The intubation tube, you have a connection outside.
intubation. We do the intubation of the canaliculus. It is a bigger tube,
Yeah, that's what.
and then we
stand
there.
away and then do inject it. That's what I was wondering how it was done.
Yeah, that's right.
So, any questions from you, Dr.
Yes,
Indira?
sir, I have one question. So for the practicality, sir, as you are saying that this is not, this is one of the first you have done, sir. So who is going to do in future? In future, if you are advising, so
I have shown 3, 4, 5 representative cases.
yes, sir.
Patient, in one patient I have shown the dacrylith in the mid
Yes, sir.
segment of the, actually usually 99.9% times dacrylith lies in lacrimal sac only. And because of repeated syringing, it gets dislodged and went into there.
Yes, sir.
So these patients who have persistent epiphora, but in actuality, the pathway is obstructed somewhere, and because of the patent syringing, they don't get the specific treatment. That is the, it is important. And number 2, there is no interference. Of course, the fluorescein dye test should be the first test,
Yes, sir.
and second test should be this. There is absolutely no need why to interfere with the patient
Yes, sir.
when you can get this thing very easily and correctly.
Yes, sir. Sir, in any kind of dye test, we have a particular timing. We have a particular timing that at this time we will take a image. At this time we will take an image, sir.
Yeah,
While flowing
that's
out.
right.
So
That's
have
right.
you
I will tell you.
decided? Yeah.
I will tell you. We have been doing it since 1917.
Yes, sir.
We have 840 plus cases. We have done exposure 1 minute, 2 minutes,
Okay.
3 minutes, and 5 minutes. Here I have shown, because fluorescein dye disappearance test is taken as a after 5 minutes.
Yes, sir.
But we have a full series of 3 minutes, 4 minutes, 5 minutes, 2 minutes. In fact, the dye, once put in, instilled in the sac, conjunctival sac, it reaches in less than 1 minute in inferior meters.
Okay.
And everybody must have tried it. Whenever he puts a
Yes,
eye
sir.
drop, you get the taste in your mouth. So there is absolutely no point. We have a clear-cut proof that there is absolutely no point to wait for 5 minutes, as we do in fluorescein dye disappearance test. After 5 minutes, we get the cases which are partially obstruction. Even those cases become the positive or negative. So this is again a different series.
Yes, sir.
So that is a different paper altogether.
Yes, sir. So in future, if we are going to do it as a test, we are going to standardize this as a test. So we have to give some instruction to the person or the technician who is doing, or a doctor has to perform the test, sir.
No, this test is being in my premises.
Yes, sir.
This physio-maxillary surgeon is adjacent to my premises.
Yes, sir.
So they know that I'll write, take the exposure after 2 minutes, take the exposure after 3 minutes. Sometimes we call the patient again next day, we'll do it again
Yes, sir.
after 5 minutes.
This is exactly my question, sir. So for the practicality, we won't have a maxillofacial surgeon beside us, or if it is going to be an standardized investigation, so we have to give a particular instruction that at this time, at 1 minute we want, at or seconds, 50 seconds, 60 seconds. So how are we going
now
to?
we have almost standardized it
Yes,
for
sir.
our setup.
Yes, sir.
It is 3 minutes.
Yes, sir.
And in cases, if we need it, we do it at 5 minutes. In some patients, we do it after 15 minutes. And that is a different story, and we are going to publish the full series.
Okay,
So
sir.
it is there, everything is there.
Thank you.
I
Thank you
had
so much,
only
sir.
8 minutes. So
Thank you, sir. Thank you
thank
so
you.
much.
No, here it is not there.
We go to the next talk. Dr. Pooja, you're welcome. Please stick to the time.
Sorry. Yeah, you can start.
Yes, start it.
In our fast paced, technology driven world, myopia is becoming increasingly prevalent. According to global data, the prevalence of myopia has doubled in the last few decades, and it's estimated by 2050 nearly 5 billion people around the world will be affected. As myopia rates increase, so does the need for refractive surgery as it reduces dependence on glasses or contact lenses. Corneal refractive surgery has undergone significant evolution, improving its effectiveness and safety over the years. Today's young patients are notably well informed with widespread access to digital information regarding laser-based vision correction. They expect higher precision, safety, and outcomes from modern vision correction technologies. In summary, the evolution of refractive surgery reflects ongoing advancements aiming to enhance precision, reduce recovery times, and improve patient outcomes. Refractive surgeons commonly face several fears and concerns. They worry about plane identification, tougher dissection, and retained lenticules, which can affect the outcome of the surgery. But the connection amid these fears is the way lenticule is dissected and extracted. We know that more tissue manipulation leads to subclinical edema, affecting the quality of vision post-operatively. So we took a look at advanced corneal refractive surgery platforms and observed that they differ in their specific laser parameters and applications. So we decided to use this advancement in technology to patient's advantage to provide enhanced quality of vision. We first hold the lenticule gently with the forceps and exert traction radially to pull the lenticule from the surrounding stroma. But not just that, we also wanted to see if this technique is better than the conventional dissection technique. We found that patients had better quality of vision as we can see through the objective scatter index and also through better point spread function. This technique is repeatable and more reassuring for the surgeon.
Thank you, sir. Thank you, ma'am.
You have a series of these patients who are compared.
Yes,
So,
sir.
according to you, today, which procedure you will prefer? Peel or
Sir, it's like experience, like how we go in cataract from ECC to SICS to
agreed,
phaco.
agreed. See,
Like capsulotomy to capsular excess, first we have to learn dissection and master the dissection. After we are comfortable with dissection, you go ahead and do the peel technique. And
Yeah.
if you feel comfortable, then you can apply it for
no,
almost 90
my
case
question is
procedures.
simple. You have tried both that. Now I want to understand from you, because you are experienced in this, that
Yes, sir.
which one you prefer. I said you prefer
Sir, I prefer peel. I do it for my 95% of cases now.
with peel.
Yes, sir.
Okay.
5% cases, we are not able to do it, so we stick to the traditional method.
Just continuing with the question, why not in the 5% of the cases?
So sometimes the corneas are very thick, or the biomechanics, the strength of the cornea is very hard. So in those cases, there is an excessive OBL. So if you try to do a peel in that thing, you can see the OBL in the after the laser firing. If you try to do peel, there can be a retained or a toned lenticule. So if I see that there is an excessive OBL at certain area, or if I feel there is a resistance in doing a peel technique, I switch back to dissection.
Yeah.
So that's the 5% cases. Sir.
Yeah, because technically it is not much different from what a cataract surgeon would do, like, So why would you insist that first learn the conventional technique and then evolve to this technique? Because it is just holding and tearing on either side.
Sir,
So
as I mentioned, sometimes the peel doesn't work. So
Okay.
if I don't know the
Acha, okay. As a
traditional-
backup technique, you should be knowing.
Yes, sir.
Just like you have to be good at SICS.
Absolutely, sir.
Okay, I get your point. Now you showed the outcomes in terms of the performance. How many patients were there in the series in both the cases for you to come to conclusion?
So when I had first made this video, it was 150 eyes for. We have done a contralateral eye study.
Okay.
Now I have experience with more than 1,000 eyes.
But yeah, the presentation would carry more impact if you have the data. comparing
sir.
this.
I think
Okay.
we submitted this 6 months back. So now,
Okay. No, whatever it was then
Yes.
also, no, whatever
Yeah.
data you had then also, if you put it, it is more, it has an impact.
Yes, sir.
So that is what I was. And second thing, what have you documented any structural changes? So you definitely felt that there is an advantage. You assessed in terms of the performance post-op, but structurally, no, does it cause less damage to the interface, so that the healing is much more seamless? If you if you had shown us those images, structural changes, like
So there were some confocal images.
few confocal images. Yeah.
For the same patient, contralateral eye dissection and peel, which showed that in peel there was minimal activation of keratocytes, or in the interface there was minimal edema on day one,
Yeah.
having better quality of vision on day one.
Yeah, but if you had highlighted that frame, okay, and pauses, it just went passing by.
Yes, sir.
So just as a cinematic, when you're telling a story, you have to focus on these. It gets more impact.
Yes,
So I missed it. So you say it is there, but I couldn't see it. I saw only the visual acuity chart, those things I saw, but that I just a comment.
Yes, sir. Thank
Dr. Indira, please.
Ma'am, I just wanted to ask about, give some light on the repeatability of the procedure, madam. Like if it is incomplete in between, or how do we, like you are saying we can switch back to the basic plan. So how do you get the switch? Or how that repeatability works?
Ma'am, it is quite repeatable, as I mentioned, that we are able to do it now consistently for all the patients. If there is a challenge, we just take the dissector, the blunt dissector, and switch to the dissection technique. And whichever step you are, like let's say get stuck and you switch to dissection technique, you are easily able to do it, provided you go in the right plane. So the only thing is it's repeatable. You have to identify the right plane, anterior and posterior.
Okay. Do you like if one part of it is incomplete, then you again try it again and then go to dissection? Or
Yes, ma'am. I first try to, so if it's incomplete, we try to leave the lenticule, grasp the lenticule with little bit more hold, and then try it again. If it doesn't work, then only switch to dissection.
Okay, ma'am. Thank you.
This is the point I was trying to make, that what is the point when you're grasping it, and do you get any feel that this will not come out and this will have some adhesions or some separation?
Yes, sir. When I hold
So
it,
what
and
is
if
the point? I mean, do you see any strias coming in there, or what do you see visually? Because this is something your feel and your eyes coordinating to understand that this lenticule is going to be smoothly coming out. And now this is a tuck, or whatever. I mean, I want from you, because you have experience on this.
Sir, so before starting only, if the OBL is dense, like if you see those very dense OBL or white, like now you don't see the bubbles, but you see a white structure, then we don't attempt it because we know it will not have it.
That's the point.
But visually when we start, at this point of time, we don't have a sign of when to stop, but resistance. You feel resistance while you're doing it, that's when I stop.
Yeah, probably this elaborate study should give us these points.
Yes, sir.
because-
Yes.
Thank you so
sir.
much.
Thank you, sir. Thank you, ma'am.
Can we go to the next? You can call.
Next video would be VT451, basic nasolacrimal endoscopic evaluation with a handheld digital device. The presenting author is Dr. Obaidur Rahman.
Good morning to everyone present. Can we have the video? Yeah.
This video demonstrates basic nasolacrimal endoscopic evaluation with a handheld digital device. The authors have no financial disclosures or conflicts of interest to report. Acryocystorynostomy is a common oculoplastics procedure, with the external DCR approach being more commonly performed. This surgery creates a conduit into the nasal cavity. However, nasal examination is often overlooked. In India, only about 50% oculoplastic specialists perform pediatric probing under endoscopic guidance, while the rest half still perform a blind procedure. The relevance of nasal endoscopy in DCR. It helps in delineation of nasal anatomy and identification of anatomical variants and pathologies, post-operatively can be used for assessment of ostium size and functioning, as well as complication assessment. Ophthalmologists face two major roadblocks in performing nasal endoscopy. The first one being lack of access to expensive instrumentation and lack of training, and the second one being lack of knowledge about nasal anatomy. To address these two roadblocks, the authors used a digital otoscope device. Originally, this device is an air wax removal otoscope which was used for nasal endoscopy by the authors. It has a 4.5-inch LCD screen and a connectable camera probe. The camera probe has 6 LED lights for illumination, 1 megapixel camera with an excellent photo and video resolution, a working distance 20 millimeters, and can be easily charged with a mobile charger. The authors use this device for performing nasal endoscopy in external DCR patients. Here the middle turbinate is seen, and as we move along the floor of the nose, we can even see the nasopharynx behind. Preoperatively, the authors used this device for documentation of 6 landmark structures relevant to nasal anatomy in DCR, namely the lateral nasal wall, the nasal septum, inferior turbinate, middle turbinate, axilla of the middle turbinate, the maxillary line. Intraoperatively, this device was used for documenting the ostium. The ostium with the internal opening of the common canaliculus could be visualized. This device was also used for endoscopic probing in pediatric patients. Here, the metallic probe can be seen hitting the floor of the nasal cavity. Post-operatively, this device was used for ostium assessment. Here, a dynamic 1-month ostium can be seen. This is another 6-month ostium with egress of clear fluid. In patients with silicone stents which were retracted after surgery, this device was used for visualizing these silicone stents and removing them under direct visualization. Here, syringing is performed after silicone stent removal. Post-operative complications could be documented, such as anterior nasal synechial formation, synechial closure of the ostium causing DCR failure, and granuloma formation around silicone tubes. This device could be used by DNB residents and fellows for performing independent nasal endoscopy after training. 13 trainees were trained using this device, out of which 46.2% had never observed nasal endoscopy before, and 84% could not identify more than one structure. After training with the device, 76% could identify all the structures correctly while performing endoscopy independently, while 84.6% believe that endoscopic teaching enhanced their understanding about lacrimal drainage and DCR ostium. When comparing this digital device with the conventional endoscopic system, it is easier to use. It has a smaller learning curve. It is portable, can be carried in the pocket of a shirt. It is battery operated and does not depend on external electricity sources. While the conventional system has a better image quality and a longer working distance. Talking about the cost effectiveness, this device is much cheaper when compared to a conventional endoscopic system with all its equipment. In conclusion, the digital otoscope device is a low-cost, handy utilitarian device which can be helpful in resource-limited settings and peripheral setups. It is easy to use and portable. It can be used for documentation and for teaching. The images and videos captured are easy to transfer and share. Thank you.
So you started with pediatric probing, sir. All I think most of the images are adult. So have you tried like in children?
Yeah, so one of the images, one of the videos showed, in fact, was about pediatric probing
Yes, sir.
in between. So yeah, I've done pediatric probing also with this system. So initially, when I did not have access to an endoscopic system, for about 1.5 years, I've used this device for pediatric probing also, and for minor procedures like silicone stent removal and studying nasal anatomy, both preoperatively and postoperatively.
Okay. The size is very big, sir. Like, is it like the probe comes with a different size, or like it's the same?
No, the probe is same. The probe size is 3.9 millimeters.
Okay.
The nasal cavity diameter is around 12 millimeters. So even in children, the probe can easily go into the nose. And in children, we don't have to go further. We just need to see the inferior turbinate, which is very anteriorly placed.
Okay.
So you don't have to go posteriorly. Just inserting the device just beyond the external nair can help you visualize the inferior turbinate.
Okay. Sir, one more last question.
Yeah.
What about the sterilization, sir? How, because nasal mucosa, it's very, easily infection can spread through that. So how do you
Yeah, so in the OPD setting, I'm using alcohol soaps for cleaning and then allowing it for air drying. And in the OT, we're using gas sterilization for the device.
Any complications you have encountered during your training period? And I mean, are you proficient that 85% is reasonable to allow anyone to go ahead and use this procedure?
So basically,
because the ENT people, they take long time, and with exposure to those big screens and nice equipments, and if you start doing it for children and all, it will be something to be worried about.
Yeah, thank you for your question, sir. So this device is being used only for diagnostic purposes and not for therapeutic purposes. In fact, pediatric probing is perhaps the only therapeutic procedure that is being done. So any lacrimal surgeon, or for anyone who's dealing with lacrimal system disorders, they must know at least the basic nasal endoscopic evaluation, and that was the aim of the study also, of the training. So we are not expecting the trainees to know advanced procedures or advanced anatomy, but only the basic nasal anatomy of the anterior structures, at least, what is relevant to the lacrimal system.
And do you think this device can complement the endonasal procedures as a part of the surgery also? If you are sometimes trying to find out exactly location, because there are sometimes the turbinate bone could be not exactly where you would like it.
Yeah. So I have used this device to document abnormal anatomy also preoperatively, and in some of the DCRs who were failed DCRs, we could actually see what was the reason for failure, because we studied it from the inside. And as I said, in India, still only 50% oculoplastic specialists are doing it under endoscopic guidance, which is the ideal thing to do, especially in children.
I think that would be ideal, yeah.
Yeah.
Thank you so much.
Thank you.
No, it's okay, fine. Okay, so we reached the last presenter. May I request Dr. Manisha? You want to? Not now, sir. Not now. The last speaker. Stuffing can help to avoid RD. Manisha.
Good morning, everyone. A 60-year-old gentleman. A 60-year-old gentleman presented with sudden painless diminution of vision in the left eye 1 year back with no vision in the right eye. He had a history of high myopia in both the eyes with a refraction of -13 diopter in the right eye and -15 in the left eye. On examination, the right eye showed a chronic retinal detachment with a vision of PR inaccurate, and the left eye had a vision of PR accurate with a tessellated myopic fundus with posterior staphyloma, a full thickness macular hole with a total retinal detachment. The left eye had undergone a pars plana vitrectomy with membrane peeling and ILM peeling, with fluid air exchange, endolaser and silicone oil injection 2 months back. Post-operative follow-up at 2 months showed a well-attached retina with a persistent macular hole with SRF in the area of the posterior staphyloma under silicone oil. The dilemma in our mind was that there was evidence of persistent SRF at the posterior pole with an open macular hole which was hampering the visual improvement due to a detached macula, and the silicone oil removal could not be planned in future as it had a high risk of a recurrent RD. The patient was thus planned for an amniotic membrane graft in the persistent macular hole. An infusion cannula was fixed with silicone oil injection. A soft tip cannula was taken and an active suction was done to remove the persistent subretinal fluid under the macular hole and in the area of the posterior staphyloma. Amniotic membrane of adequate size was taken after staining it with BBG dye. End gripping forceps was used to insert the amniotic membrane graft in the persistent macular hole. The entire procedure was carried out under silicone oil itself. Whatever loss of the silicone oil was taken was overcome by injecting the silicone oil. Post-operative follow-up at 1 month showed a visual recovery of 4 by 60 with a well-attached retina and macula with amniotic membrane graft seen plugging the macular hole. This made the patient ambulatory again. The patient underwent silicone oil removal after 6 months. The patient continued to maintain a vision of 4 by 60 after the silicone oil removal with a well-attached retina and macula with an amniotic membrane graft in place. Therefore, never give up.
You have some narration also, or that's end of your paper?
That's the end, sir.
Okay, great. Manisha, I would like this stuffing has become a part of your armamentarium in every macular hole.
Not at all, sir.
But then, which holes you decide that, because size you didn't mention exactly that.
So these are not the routine cases of macular holes, sir. Here I have specified a specific situation of a high myopic patient with a very large posterior staphyloma with an open macular hole. The first surgery where we did the surgery for the retinal detachment, we actually went ahead and did a regular ILM peeling. But because there is a shortening of the retina with that posterior staphyloma, that ILM peel was not able to close the macular hole. So after the first surgery, the patient did have a very well-attached peripheral retina, but continued to have a detached macula leading to a large central scotoma. And the patient was not ambulatory because he was a one-eyed patient. So in this particular situation, we were left with no other option. Either the option was to have a macular buckle, where we are not skilled to do that procedure, and you know that it has a very high risk of complications. So that's why I thought that this is going to be an alternate where you can just mechanically close that macular hole, which probably could result in the drying out of that subretinal fluid in the macular area, and probably could result in the, again, reattachment of the macula.
So at the first time when you operated, you could not think of putting the ILM flap.
I've done that.
You did that?
I did that. I did the
in spite
ILM.
of it?
Despite that, because there is a big crater underneath the macular hole with
shortening.
That. Exactly, because of the shortening of the retina, sir.
Because in what way this stuffing will increase the that area? I fail to understand.
It's not really increasing the area, so it's just not.
So is there a still gap between that?
No, it's not allowing the liquefied, the fluid that you are leaving inside the eye to percolate under the persistent macular hole. So after you have done a fluid air exchange also, you have had the fluid going under the macular hole in the first sitting. So you have the vitreous cavity full of silicone oil, but you still have that persistent subretinal fluid under the macula, which is not settling down. So here what we have done is we've actively sucked out that subretinal fluid and mechanically closed the macular hole, and that has helped to resolve the problem.
But could you think about injecting something behind the choroid to push the choroid forward?
it would be very dangerous because it's a very posterior located.
But then we have no other choice left, because if that cannot come here, because I'm very happy that you did something which is unique.
Thank you.
Any other questions, sir?
Yeah, my question was, would it be, you didn't anticipate that the macular hole would not close after the first surgery. So I was wondering, why wouldn't you attempt in the first setting itself? Because the persistent macular hole is the most common cause for redetachment of the RD, or resolution not failing to resolve. So that was my question.
So, sir, what we need to understand, like sir also mentioned, majority of the macular holes, they close just with an ILM peel. So that is going to be our first resort to close the macular hole. But here what I'm trying to highlight is that it's not like a routine retinal detachment with a macular hole. Here we are dealing with an eye which is highly myopic with a posterior staphyloma. And also in these cases, because of the myopic maculopathy, the contrast is very poor. When we are doing the ILM peel, even in the first surgery, it's a very difficult procedure, because despite having stained the ILM with the BBG dye, because you don't have a contrast behind, it's just the sclera which is showing up, you're not really able to do a very excellent ILM peel. So in this situation, the situation is tough in the first surgery, where you're just wanting and aiming to redetach the retina. But here, because of that persistence of the subretinal fluid pocket in the area of the posterior staphyloma, the patient had a central scotoma, and the patient was not able to move around comfortably, though the peripheral retina was well attached. So that is why it was thought that maybe under the silicone oil itself, if we can mechanically close the macular hole, it probably could result in a reattachment of the macula.
I think we've finished judging. So if now this house is open, can we let it questions coming in, sir? Because we have 15 minutes to...
I think the thing is, usually the question and answers are restricted to judges.
No, we finished judging. So I'm saying is because people are interested, we have 10-15 minutes left with us. It's just a suggestion. I just have a question. Yeah, that's why we can take.
No, he is going to mark only from the rest of the videos which.
Don't worry, Kumar. I'll make a mention that this has been.
No, he'll be judging only the videos which he has seen.
And
from number 3, sir. I think number 3. You have seen from number 3, I guess.
Yeah. So I'll cut these marks also. So if there are no questions, you were saying something. I think there's.
You can now. Okay, you can discuss.
Yeah, because another we have. I have cut these two. That's it. So no question, no problems. Tremendous, great. Yes, any other comments? Because, yeah, please go ahead. We have 5 minutes, so. After.
Yeah, definitely, sir. But sometimes the probe is hidden under the mucosa, or sometimes there is a cyst. I have documentation of that also, sir, where you need to open the cyst sometimes, or when there's a buried probe, the direction of the probe needs to be changed to come out of the mucosa. That is hard to understand without endoscopic guidance. So while I was doing blind probing procedures, there were failed probing attempts where it was hitting the bone. But once my fellow was doing a probing and I was guiding her endoscopically, and she told me there's a bone. It's hitting the bone but not coming out. It was a failed probing. And when I checked it endoscopically, actually it was a buried probe under the mucosa. And when I told her, the direction was changed, and it actually turned into a successful probing.
Actually, it is the age. If we are doing probing up to age of 12 months, it is almost 100%. You can say the parents, it will be fine. After 12 months, it is if it is 18 months, you may have these problems. But up to 12 months, we have never seen, we have never observed so far. That is my experience.
Thank you, sir.
Any other comments or anything? Otherwise, we thank the organizer of this session, and we thank the Indian Ophthalmology and APAO for this opportunity. Anything else, sir, you'd like to say? So thank you so much for coming.
Okay, just we or our judges have marked the marks individually, and they'll be sent to the scientific committee. And the scientific committee is going to do the compilation and then probably announce you the results by today evening or tomorrow. So I think it's a tough task for us judges to judge such wonderful presentations, and and you've got every right to be angry if some of you have not got to it. But it is luck, luck is the biggest deal. You have to have it here, frankly speaking. So wishing you all the best, guys. Everything was most of it, and all of you are wonderful, and all the best.
Once again, thank you so much.
We can have one photograph.
Yeah, please. May I request the official photographer to please come? And all the people presenting their papers, please come forward.